Welcome. Today we're diving into a complex and often perplexing heart condition, idiopathic ventricular fibrillation. This is a life-threatening arrhythmia, but what makes it particularly challenging is its idiopathic nature, meaning we don't always know the underlying cause. Join us as we unravel the mysteries surrounding this critical condition. The term idiopathic is key here. It signifies that the usual suspects, coronary artery disease, structural heart defects, or electrolyte imbalances aren't present. In idiopathic ventricular fibrillation, or IV-Fib, the heart appears structurally normal, and routine tests don't reveal an obvious reason for the dangerous electrical storm that occurs. This lack of a clear cause makes understanding and preventing IV-Fib a significant medical challenge. While a genetic predisposition is suspected in some cases, often the trigger remains elusive. Ventricular fibrillation is a chaotic, uncoordinated electrical activity in the heart's ventricles, the lower chambers responsible for pumping blood to the body. In IV-Fib, this chaotic activity arises spontaneously, without any apparent structural or electrical abnormalities to initiate it. The rapid, irregular signals prevent the ventricles from contracting effectively. Instead, they quiver uselessly. This stops blood flow, leading to cardiac arrest. Without prompt intervention, the brain and other vital organs are deprived of oxygen, resulting in rapid deterioration and potentially death. IV-Fib is a relatively rare condition, which contributes to the difficulty in studying it. Because it often occurs in individuals with no prior history of heart problems, epidemiological data is limited. It can occur at any age, but it seems to be more prevalent in young to middle-aged adults. Sudden cardiac death, especially in seemingly healthy individuals, may be the first manifestation of IV-Fib, highlighting the critical need for awareness and preparedness. The scariest aspect of IV-Fib is often the lack of warning signs. Many individuals experience no symptoms before the onset of ventricular fibrillation. The first sign is frequently sudden collapse and loss of consciousness. There may be gasping or labored breathing initially, but this quickly ceases. Without immediate intervention, the individual will stop breathing entirely and have no pulse. These are the signs of cardiac arrest, a direct consequence of the heart's inability to pump blood effectively due to the fibrillation. Diagnosis of IV-Fib is typically made retrospectively, after a cardiac arrest has occurred. An electrocardiogram, or ECG, recorded during the event will show the characteristic chaotic waveform of ventricular fibrillation. After successful resuscitation, extensive testing is performed to rule out any underlying heart conditions or other causes of VF. This includes echocardiograms to assess heart structure and function, coronary angiograms to check for blocked arteries, and blood tests to evaluate electrolyte levels and rule out other potential triggers. When all other possible causes are excluded, and the individual has a structurally normal heart, a diagnosis of IV-Fib is considered. While there aren't distinct types of IV-Fib in the same way we classify other heart conditions, it's important to recognize that the underlying mechanisms might vary between individuals. Some cases may be related to subtle, undetected electrical abnormalities, while others might involve heightened sensitivity to adrenaline or other triggers. Understanding these individual variations is an area of ongoing research. The primary treatment for IV-Fib is immediate defibrillation, which delivers an electrical shock to the heart to restore a normal rhythm. CPR, or cardiopulmonary resuscitation, should be initiated immediately and continued until defibrillation is available. Long-term management often involves the implantation of an implantable cardioverter defibrillator, or ICD. This device continuously monitors the heart's rhythm and delivers a shock if it detects ventricular fibrillation. Medications, such as beta blockers or antiarrhythmic drugs, may also be prescribed to help prevent future episodes, although their effectiveness in IV-Fib can be variable. Because the exact causes of a V-Fib are often unknown, primary prevention is challenging. However, maintaining a healthy lifestyle, including regular exercise, a balanced diet, and avoiding smoking, is always beneficial for overall cardiovascular health. Individuals with a family history of sudden cardiac death or unexplained fainting spells should discuss their risk with their doctor. Raising awareness about CPR and the importance of readily available defibrillators in public places is crucial for improving survival rates in cases of sudden cardiac arrest due to IV-Fib or any other cause. The prognosis for individuals with IV-Fib varies. The presence of an ICD significantly improves survival rates by providing immediate treatment for recurrent episodes of ventricular fibrillation. However, the risk of future episodes remains, and ongoing medical management is essential. Recent research is focused on identifying genetic markers that may predispose individuals to IV-Fib and developing more effective strategies for preventing and treating this challenging condition. Exploring subtle abnormalities in heart electrical activity through advanced mapping techniques may also help improve diagnostic and therapeutic approaches. Ultimately, understanding the underlying mechanisms of IV fib will pave the way for personalized treatment strategies and improved outcomes.